Stanford University.
Well, tonight we're going to complete our journey, which began with a very focused discussion, as you remember, on the physician and society, and then delved into DNA and has explored our inner and outer world to address what is, I think, for all of us, becoming increasingly an important recognition, which is that we're really part of a global community, and global health is very much part of that and impacts our security and the world we live in. You know, my own first lesson for that began when I was working at the NIH some years ago on HIV infection, largely in children, and we made significant progress. In fact, we were proud of ourselves for having had a big impact on the disease in the United States, which had had just a few thousand children altogether who were infected with that virus. And the recognition of reality set in when it was clear that there were about 1,800 children being born every day with HIV infection in Africa. And this, I think, underscores the vast disparities that exist today in a variety of different diseases, many infections, but many others as well that affect adults and children throughout the world. Now, when people think about global health, and certainly in academic medical centers, they sometimes use the word international health. They have very different perspectives. Sometimes it's about, as has been the case at Johns Hopkins and Mayo, about bringing patients from other parts of the world to receive medical care at their center. That's a very different kind of global health than we're thinking about. We're thinking about the impact on communities that really suffer the consequences of a lack of availability of healthcare as we know it and take for granted, or the resources that will enable them to even distribute the healthcare if it's accessible. So tonight we're going to address that on a sort of case-based study, and then move up to kind of a macro view of some of the big challenging issues and policy issues that exist around global health. So we're going to start, because tonight, unlike any other of our events, we have two speakers, so we're always looking to break new ground. But tonight we're going to start off with Sherry Wren, Dr. Sherry Wren, who I've introduced to you on a number of occasions because she's, as you know, the course co-director. And Sherry, who I've gotten to know quite well since I've been at Stanford, is someone for whom my own admiration has grown enormously over the years. She is a surgeon by training, deals in oncologic surgery, some of the most difficult and challenging cases, working primarily at the VA hospital. She works in the area of trauma. She is moved beyond surgery, at least here at Stanford, to be one of our deans in academic affairs, representing her leadership continuum on the role of new journeys, and I really have enjoyed working with her in those spheres. But the part that has been real recognition for me is to see the real personal, I would say, heroism that she's had in traveling to different parts of the world and dealing with some of the really significant challenges. And she's going to share that experience with you. And then we're going to proceed from Sherry to one of our newest recruits at Stanford, who's Michelle Berry, who joined us just this past year after close to 30 years overall at Yale. And we've been stealing a number of faculty from Yale. And she's one of them. We've been very successful this year. Good that the East Coast is down. And Michelle is recognized around the world as one of the leaders in global health. She really established one of the very best programs at Yale, which was one of the reasons why we were interested in recruiting her here, because we wanted to further our efforts in global health, and she's really helping to unite the forces here at large. She, in addition to her academic work, which has been highly recognized, including election to the prestigious Institute of Medicine of the National Academy of Sciences, is on the board of the Gates Foundation, and has many other advisory roles that really equip her with the knowledge and skills to handle the challenges that are faced in this area. So we're going to begin with Sherry Wren, move to Michelle Berry, and then we'll wish you well and hope that we'll see many of you in January. Okay, Sherry.
Great. If I could just ask that the lights get turned down. Thank you. I wish my mother was here to hear that introduction. And yeah, one of the things I hope that you'll see tonight is I've had a lot of personal experiences doing global health, and I'm so thrilled that Michelle Berry's been recruited here, because what I actually know is that I am not the solution to this, and we need to look at a much bigger level. I do need to warn you, there are some, this is a mini med school, so I'm going to show you medical pictures. If you don't want to look at them, just close your eyes, they'll change fairly quickly. But there are some very graphic pictures here, but this is the work that I do. So I have spent a large part of time in the Democratic Republic of Congo. And I think everybody remembers Joseph Conrad's book, The Heart of Darkness, which is, it's a fabulous book. Congo is a beautiful nation. There are wonderful people there. And unfortunately, there's probably somewhere between, I don't know, 500 to 1 million people within areas of the Congo because of civil unrest that are what we call IDPs, internally displaced people who are always on the move. And when they're on the move, this is what they call home. That's a homemade camp. I'd actually like to dedicate my talk to this man. I'd known Jackson for 2 years. I've worked with him extensively. I've spent nights with him working all night frequently. And just this summer, when I was in the Congo, he got shot to death in the unrest there. And it was an unbelievable thing, not because, yes, it scares you, and hearing gunfire and all those things is a little scary, but what was the most impressive thing to me is this man was a hero in his community. He was a local Congolese person who was able to go to school. Primary school costs about 10% of their income, which is that's a lot of money, and was able to go to nursing school. And the nurses at the hospital I work in are sort of superstars in the community because they've been able to get education. When he was shot and we brought his body to the hospital, the entire hospital, if they could walk, all the people, their attendants, and the entire community came out to pay homage to this man's open casket. So he was just a fabulous person, and I'd like to remember him. I sort of have always found that this phrase by Mahatma Gandhi is very true: be the change you want to see in the world. I guess I'm still working at that. All the pictures you're going to see here today are pictures actually that I have taken from my personal journeys. Why did I do this? I think everybody has their own reasons. For me, I've always been very interested in service. I've sort of spent my career in counties, VAs, working with underserved. So this was not a big jump. I wanted to go overseas, though. I was at a point in time in my life where I could do that. And I wanted to go with a non-denominational group. There's nothing wrong with faith-based, but there are differences. And I really wanted to focus on crisis situations. And there's very few places that you can do the kind of work that I wanted to do. And I ended up with Doctors Without Borders, which the whole rest of the world calls MSF, Médecins Sans Frontières. I put some brochures upstairs if people are interested in. It is an independent humanitarian aid organization, and their purpose is really to provide emergency medical assistance. They are not there for the long term. They're not the solution to global health. They're there only for short-term needs. And more than 85% of their funds come from people like us. They actually will not take donations from companies such as tobacco, because in some of these countries, or oil, that may be part of the insecurity. They're actually the largest healthcare provider in the world and provide more than 10 million patient visits a year. So as a surgeon, everybody always thinks about global health. I always feel surgery is just becoming known to be part of global health, because everybody thinks of infectious disease and pediatrics and internal medicine, and nobody ever thinks of surgery. But if you actually just think about trauma, it is one of the biggest killers across the world, especially in developing nations. So you have war, civil wars, disasters, natural disasters, refugees, IDPs. So there is a huge amount of need for surgeons, and there aren't a lot of surgeons in these countries. I've been throughout Africa. I've been in Cote d'Ivoire during their civil war. I was in Chad, the refugees coming over from both the Central African Republic and from the Sudan are all in Chad. And the last 2 years, I've spent a fair bit of time within the Democratic Republic of Congo. This is actually a quote from Joseph Conrad, and you can see as you read the quote, this is published over 100 years ago, and based on what I'm seeing when I'm in the Congo, nothing really has changed, unfortunately. People still really are dying of problems, starvation, and disease. Does anybody in the audience actually know what this is, what this child has? Pardon? Scoliosis. Nope, not scoliosis. And Michelle Berry, you cannot answer. Neither can you. Anybody? Somebody said it, I heard it. Tetanus. Tetanus. Yeah, so this is a disease you're never going to see like this in the United States. And when I got to the Congo this year, this little boy was affected, and this is unfortunately, he'd been affected very long. He's going to die. And the discussion was, should we put some type of feeding tube in his stomach to be able to try and feed him? A tetanus shot doesn't cost a lot of money, but these people don't even get a tetanus shot. So if you look at the life expectancy in Africa, we live a long time, and in the DRC, they live about 53 years on average, but it's very interesting. It's an incredibly young population. So the majority of the population is quite young, and you can see, depending on where you are in Africa, it can even get lower than that. The Congo itself, this has been the worst conflict in Africa. It's been going on more than 13 years at this point in time, and this represents the greatest loss of life since World War II. Almost 6 million people, I mean, it's kind of hard to count, but about 6 million people are dead, and 1,000 to 1,500 people are dying a day. And they're not dying because they're being shot because of the war. Most of it is when there's insecurity, and this is an agrarian society, and you can't get your crops in because you got to flee, then people begin to get disease because they're starving. And for whatever reason, this has been one of the most underreported humanitarian crises. And we could have a huge debate as to why this is. Just a little brief history. This conflict has been going on. Congo is an incredibly wealthy country. They have coltan, which goes into every cell phone, gold, diamonds, you name it. They have everything. They have billions of dollars of resources there. Of course, the average per capita income is $184. And trust me, there's rich people getting stuff out. And in fact, that's fueling a lot of the conflict because soldiers actually control some of the resources. It's intimately tied up with Rwanda and Uganda. And in fact, the Rwandan genocide in 1984, initially when there's been instability in Rwanda for a long time, and for a while the group that actually liberated after the genocide was based in the Congo. So after they liberated, and the Hutu in Interahamwe then had to flee Rwanda because they're now hunted. And what did they do? They went and set up shop in Congo. So then there's all these other forces that said, oh my God, we've got these people here, so we got to make our own armies. And this actually Laurent Nkunda is a messianic general. He was arrested a year ago in Rwanda, but he actually fielded an unbelievable army. He's not, and it wasn't the national army. There's always a recent peace treaty. They're trying to integrate the groups into the national army. But you know, the army doesn't really get paid, so they're kind of prey on the private citizens. And there's about 20 different armed groups in this Kivu area, including the largest peacekeeping force on the ground from the United Nations. The bottom line is, these are the people who have the guns, and for the civilians, it's insecurity. Rape has been used at a level that is unheard of in this conflict. Assault, robbery, burnings, and basically, if you ask people who did it, it's a soldier. You actually probably don't know who they were, which side. I was in Rutshuru, that's where the hospital is, and this was built in the 1950s by the Belgians. It's a reference hospital, meaning it was a place back in the old days where they would send complicated cases. In 2005, MSF came in to help the Ministry of Health of Congo actually run it. It has, with MSF running it at over 280 beds, you get more beds if you build a tent. This was actually an orthopedic tent we had going for a while. And it's incredibly busy. There's no elective cases. This is only emergencies. So there's nothing, you only get treated if you have an emergency. One of the biggest differences when you go overseas, in the United States, we are incredibly resource rich. We've got scanners and machines to do things and ventilators to help people breathe after operations and IV pumps. In these countries, you have a lot of nothing oftentimes. I like to call this my CAT scan. I have a really effective CAT scan. Actually, I really do. You learn to get really good at that. There is no pathologist, so when you take something out, it goes in the garbage can. Something unheard of here, to not have an examination of something that we took out of people. We have no way to breathe for people after surgery. I have actually taught family members how to push a bag to try and save somebody. And so you learn to make do. The hospital itself is very basic. This is the concession stand out front. You can buy bananas, sugar cane, some water, eggs, whatever. This is the kitchen area. That's where the family actually makes the food for the person in the hospital. This is our orthopedic ward. You can see there's no privacy. And these are all bags of sand of people in traction. You'll rarely see this in the United States, because if you break your femur, which is the large bone in your upper thigh, we would put a rod in to join those things and you would be up and moving right away. We don't have that, so you lay in bed for more than a month with a bag of sand, pulling your leg down, waiting for it to heal. And this was one of our 2 operating rooms. I can tell you, compared to the operating room I just left today, that's a pretty basic one. Again, the hospital was very spread out. This is, again, surgical wards, the other room, and in this area we have a bunch of camps. If you are sick in a hospital like this and you don't have a family, they care for you. They provide your linen. The hospital gives you a food ration, but they prepare it for you, and they really do your personal care. They bring you the cup to pee in, they empty it, they do everything. And this is the operating room right here, and this woman is preparing, that's manioc. I've eaten that many times. And she's just hanging out at the hospital, because that's what you do, and you prepare your food. This was our so-called emergency room. This is a French-speaking country, so sometimes I get a little confused. I'll call them by their French names. In the operating room, we have some materials, okay? There's no oxygen tanks. This is a machine that can take room air and concentrate it to about 5 liters, which is not much. We have one anesthesia machine. We would scrub things and reuse them. And, I can tell you, though, we did a lot of stuff. What do you do? In the United States, I always joke that in these days, you've got the left toe doctor and you've got a right toe doctor, because we've gotten so specialized. I'm the everything doctor. I have been a dentist. I've done neurosurgery, and it's very much out of my comfort zone. And you really, they always joke, because they know I'm a professor and they love that I come. And, but I have to say, I've probably learned more from the people there and the nurses, because they see diseases every day that I've had never seen in my life. Like the first time I saw tetanus, I had no idea what it was. So yes, I work a lot, but I do learn a lot too. What I'd like to do now is walk you through sort of the 6 somewhat major areas that, as a surgeon, in these areas that you would deal with. And the first is burns. Now this is where the pictures are these have all been happy pictures, okay? These are gonna be the tough ones now. So burns, these are child burns. And you can see I have down here that 50% of these kids are epileptic, so they have no access to medicine. So their epilepsy is not treated. So if you cook on open fire, which everybody does, and you have a seizure, you fall in the fire. And you see horrendous burns from this. And so we would treat, so this burn is actually very nice and clean now, and then eventually you can put a skin graft on it. But children were getting burned all the time, not only from epilepsy, but also because they play in the open fire and you get burned. Now another way, unfortunately, during these times where you get burned is when people light your homes on fire. And these people, unfortunately, were in their homes when they got caught on fire. This young woman, 14, scarred for life. This woman, there's actually a website called conditioncritical.org, which is all devoted to the kivus and the problems there. This woman is actually featured on this, Francois, and you can see her finger up here has died. It's died because her body, she couldn't get enough blood flow to her hand because between the burn and the infections that the burn gets. Now, in the United States, if you get severely burned like this, you end up in a highly specialized burn center. I have built a burn center in Africa. It's not highly specialized because you basically are making do with very basic things. But you can actually get a lot of these people through now, but it is obviously very traumatic to them. With the insecurity going on, especially this last year, gunshot wounds were basically almost a daily occurrence. Gunfire at night was almost a nightly occurrence. The first time I heard it, I was like, wow, we're having fireworks. And it's like, no, not fireworks, that's gunshot wounds. So now, these are not pistols. This is not like some guy carrying a 9mm and shooting at some other guy. These are military weapons, they're rifles. And this is a little 8-year-old who got shot. They make small holes, and then when they exit, they make really big holes, and they do a whole lot of damage. Now, it's actually illegal to take pictures in the Congo out on the street, so everything I take is very surreptitious, especially when you're dealing with, all the time you'd see armed people all over the place. And this is how people get shot. Now, this young man, you notice how many legs? One leg. Why? Horrible gunshot wound and amputated. So this man, and it's not like they have prostheses necessarily, so this man's life is forever changed. Now, I had an entire ward of men who had been shot. These are just a selection. There were many more. And all of these guys were shot mostly in the extremities. He was shot in the rear. This man's amputated. This man will probably get an amputation. This man is shot in 2 limbs. He's shot in 2 limbs. This man had a horrible artery injury to his leg. So it's a huge toll. These are the breadwinners for the family. This is what happens when a military weapon hits your bone. It pulverizes it. And you also get nerve damage and artery damage. This was a horrible case. This is a gunshot wound to the head. That's actually exposed brain at the base. This person survived, which in some ways I think was worse. He could eat, like his family could feed him, but he really wasn't really there. And he couldn't really move. So you've seen people who get contractures, they get stuck in a position. And every week, the nurses would ask me, how am I going to fix this? What am I going to do about this? And of course, you can do nothing in this environment because you don't have the resources that it would take. And I don't actually have the skills to do what we're doing in Iraq and Afghanistan now for our own soldiers is rebuilding a piece of skull and putting it on. And you can actually deal with these wounds, but not there. And so you feel, at times, you just feel it's very frustrating. This is more the bigger gunshot wounds. When you start getting gunshot wounds to the abdomen. And these here are right over your femoral artery because you get a lot of vascular trauma too. Now, this was something that's well known in the trauma literature around the world, but they'd actually never seen it. This is called a Bogota bag, and the reason it's called a Bogota bag is because during the cocaine wars in Bogota, Colombia, they had all these people getting horrendous gunshot wounds, and they couldn't close their abdominal walls because they got so swollen. And so what you can do is take a bag of IV fluid, take the plastic, cut it open, and sew it there, and then later on come and close this. Now, they had never seen this in the Congo, and so this was the first Bogota bag in Rutshuru Hospital, and it worked. This person did fine. But you do have to learn how to be a bit inventive. Accidents are everywhere. The most dangerous thing you can do in Africa is get in a car or be on the road. This is classic transportation, okay? And you could take this picture every day, every 5 minutes. Yeah, you pay, in fact, $2 to $3 to get on this thing, but you can see the road is sort of there, sort of not, It's used by people carrying, I mean, it's a free-for-all. And then, of course, you put as much stuff as humanly possible on one of these trucks, and you can imagine they hit these gigantic bumps and people go flying or they hit other cars, and you can get a whole lot of trauma at once. We had one night, 40 people had been sitting on top of a beer truck, and the beer's in glass bottles, and there was a big accident. That was a big mess. And you see just a huge amount of that. Now, this was one of the beer truck ladies who was sitting up there. And this was a picture I took 2 years ago. She had a horrendous ankle fracture. I actually had to treat it here with this is called an external fixator. It's a way of fixing the bones in a very dirty fracture, meaning it's infected, so they can heal. Now, how this woman knew I was back in the Congo this year, but she did. I guess the word goes out in the towns. And so she came to visit me. And this is her, and this was her sister, who I'd gotten to know because I stayed in the hospital every other night, and I used to talk with this woman a lot, and they came to visit me to show me, and this woman was actually walking really well, and I thought, wow, that was really nice to see, that I had actually fixed her ankle. I am not an orthopedic surgeon, and it was just nice to see her. This is unfortunately some of the other side of what you see. That's a machete injury to a child's head. Okay? Machetes, believe it or not, a weapon of mass destruction. You can do a whole lot of damage with a machete. Orthopedics is everywhere. These are horrendous injuries. So this one here, this is this man, he's a fisherman. Anybody know the most dangerous animal in Africa? Hippopotamuses. I've seen people killed by hippos. This guy got bit. These are horrendous fractures, and hippos' teeth are really dirty. And actually, in this environment, it's almost impossible to fix these fractures because they're just almost impossible to fix. So, you know, this man may or may not be left with a functional arm. These are the femur fractures. That's what they look like on X-ray. So in the States, you put a metal rod up this. There, it's traction. This is actually a disease that you see mostly in children. This is called osteomyelitis. This is infection of the bone. They probably get it because they're constantly getting low-grade infections. It infects their bone. And what happens is that the bone sort of rejects the original bone. It tries to make new bone, and you pull out this bone sequestrum. This is all old infected bone. So there's a whole lot of business to do in orthopedics. Infectious diseases, I've had to learn some new ones. This is one, Bruley ulcers. Mycobacteria is what TB is, but this is a different type. This is not tuberculosis. This is a bacteria that's waterborne, and 90% of these lesions end up on people's arms and legs. And you can see these are highly disfiguring, and is only seen in certain areas in Africa. Cellulitis, you've heard of flesh-eating bacteria. This is what flesh-eating bacteria looks like. There is no such thing as flesh-eating bacteria. There's multiple different types of infection, but people will literally just come in. This woman, her leg is dead all the way up to just below, you know, she's got about that much thigh. The only way to save her life, take her leg off. Otherwise, she's gonna die. Some of these other things you don't need to take the leg off for. You can just do treatment and eventually skin graft them and save their limbs. But primary infections in these countries are horrendous. Typhoid is a disease that we used to have in the United States, typhoid Mary. So it's a bacteria that if you swallow it, it can cause infection. What it does is it gets into your small intestine and it goes to what's called the Peyer's patches. I think Julie Theriot mentioned those. It's collections of lymph tissue in the intestine. And then they can die. And so you see these areas here? These are where the Peyer's patches were in the intestine. And you see how this does not look nice and pink. And from the inside, these die and then they perforate. And then the feces come into the abdomen. And this is mostly in children. And the nice thing is, if you catch them, you can fix it. And both this little boy and that little boy were these pictures. And you can see they look happy and they're doing well. Maternal and child health is a huge thing. If you could look at one thing where lots of people die, it's young children and women, especially about cesarean sections, not having access to cesareans. So about a third of what I do when I go overseas is cesareans. Now in this country, I would never do that because Legally, you wouldn't. This is actually me giving birth to doubly breached twins. Yeah. I can't say I really like young children that much, but they're kind of, when I give birth, I just kind of pass them off. It's like, okay, have the baby. Babies are not my thing. That's why I'm not a pediatrician. This is actually a French gynecologist that I worked with. And you could see here, she's showing me, okay, yeah, because you got to flip them and do weird things to them to get them out. This is, the incubator. In the United States, you see incubators. That's a light to warm up a baby. And this was the neonatal intensive care unit. Looks obviously very different. You see a lot of kids with disease. Everybody in their life has seen a belly button hernia, right? Somebody's got a poochy belly button because the abdominal wall where the umbilical cord came through didn't close down all the way. Well, this is what happens when it gets stuck out there a long time. And this little boy came in, and that's feces coming out of his belly button. And no, that's actually not that bad. Trust me, there are many worse things than that. And it's actually pretty easy to fix. We just sort of took that down and fixed it up, and you can see he did great. So you can really have a lot of impact. Now, as Dr. Pizzo mentioned, I am a cancer doctor here, and cancer for me it has a lot of special meaning. And so some of the cases that I really love being able to bring my expertise to is cancer. Now, that's also said, there is no treatment for cancer in these countries. There are no oncologists, there's no chemotherapy, there's no radiation, there's no pathologist to even tell you what kind of cancer it is. So this woman came in, she had a large mass in her belly, which I took out of her. And needless to say, she looks pretty happy and went home feeling much better. You can't always say that. This is a man, you see these dilated veins on his belly? And the reason is that his liver, this is your liver here, is so filled with tumor that the blood can't go through the liver. This man, this is a death sentence. There's nothing that could be done for him. This is an ovarian tumor, be able to take out, and this is a female organ that I just forgot the name of, uterine tumor. I work at the VA, we don't see a whole lot of uteruses. This woman came in, you could feel this. You can imagine she's bleeding from it. You take it out. Again, these people really are very grateful for what you're doing. These are some of the mystery ones. I'll never know what they are. This is a young man. At first, I thought he might have an HIV-related tumor, but we checked him for HIV, and he's HIV negative. We can't diagnose it, so all you can do is offer him an amputation because he can't really use the foot, or amputation oftentimes isn't culturally acceptable. He just goes home with that. This man heard that, of course, there was some Western doctor around, showed up. You can see this large fungating hole in his throat. He also has large lymph nodes here. I have no idea what this is. I think it's a thyroid cancer that's out of control, which is almost unheard of. Thyroid cancer should never really kill you, most types. And I could literally stick my finger in and touch his trachea. Now, this is a case that I chose not to do because I really don't have the resources to be able to handle that type of surgery there. As opposed to this guy coming in with this large ucky thing on his thigh, which is, again, probably a type of skin cancer, but with that, I judged that we could do that safely and not, you don't want to kill somebody trying to take care of that. So the sad thing is, the treatment for this is send the guy home. Everybody always wants to know, where'd you live, what'd you eat, all those kinds of things, right? So this was my home. Those are the bathrooms. This is how you take a shower. You take that, fill it with water, and then you take that coffee cup and dump it on. Millions of people in the world take showers that way. It works. That's the toilet. You get really good quads. I'm very strong now. Especially with all the dysentery you get. These are your mates that come in your room, these large bugs and things. But you know what? It's not that bad. And I love a good Four Seasons hotel, so I can do this. But what you really take away is you get to work with incredible people. You get to meet incredible people. And a lot of these people, the language there for educated people is actually French. For other people, they speak different dialects. I can actually speak a bit of Swahili now. The local language is mostly Swahili. But you can see, these people, they're living in hell, absolutely living in hell. And they are so happy to see you, so respectful. And I think they're just really, and the kids will never stop following you. If you ever go to Africa, a Swahili-speaking country, you'll be called Mzungu endlessly and have a parade of children following you. It means white person. And little children will scream in horror because you terrify them. Now, this is probably one of my favorite pictures of what a hospital is like in Africa. It's very different than an American hospital where everybody's in their own space. This is a patient, that's that woman who actually came back to visit me. She's doing the hair of somebody else's patient. The families are all there, everybody, it's a totally different atmosphere. You also tend to spend a long time at the hospital because there's no care at home. These are my Congolese teammates. These are all, it's amazing. They do have a medical school, they do train people in the Congo. There are some Congolese surgeons, I've worked with one, and they've never trained a woman surgeon. They do have women medicine doctors, but here, so these are all my team, nurse anesthetists, different nurses. All of these guys could do a cesarean section on you, no problem. They're all highly skilled. And you would think that these guys would have a hard time having a woman come and tell them what to do. Absolutely no problem. In fact, the last time I was there, I worked with 5 separate women surgeons. Don't ask me why so many women surgeons are doing this now. France, Greece, Ireland, and 2 Americans. Now you may wonder why I have on the pasta apron, right? It is a fashion statement with my stolen Stanford scrubs that I brought to Africa, don't tell. The reason is that the gowns that we wear are not water repellent. And so you have to wear a butcher's apron or this cooking apron underneath when you operate, otherwise you get people's bodily fluids all over you. So that makes it really hot. The ORs are already about 90 degrees, and then you put some plastic on. So it's a little different. So what have I learned from all of this? And I have to say that I've learned more than I've ever given. Gandhi's right, you can get really disappointed about how little you can do, but I do believe that even though I'm not saving the world, other people are going to do that. I'm saving one life at a time, and I do think that that is important. Volunteerism, I think, is important in medicine and really should be encouraged, but sending me to the Congo or to Chad for 6 weeks or 3 months is not the solution to global health. It will never be the solution. And what I think, in the recruitment of Dr. Berry and everything is recognizing that universities in the United States and the rest of the world really have an obligation to begin to help to partner to build capacity within their own country, to have their own people take care of people in their country. And I also worry as we go further because I think that as I look at training and we are becoming so subspecialized, I'm actually not sure how people are going to go in the future to do these things because, they just feel much more out of their comfort zone. I trained a fair bit of time ago at a time when we weren't so subspecialized. And I also think that our younger doctors don't do physical exams anymore. They just order tests and look at scans. So I think for them to go and learn that examining patients is actually really important is a great thing. And if anybody's interested, you had the flyer back there, but December 14th, everybody always wants to know what's it like. This is a documentary that got made. They're showing it around the country. And afterwards, they're going to have a live thing on the movie screen. Sebastian Junger, who's a great journalist, Elizabeth Vargas, other people are going to talk about this. So if people are interested, the flyer's in the back. And thank you very much.
I noticed on one of your slides it says 50% epileptic. 50%. What is the reasoning for that?
Well, I have no idea. Epilepsy, well, 50% of the burns are epileptics, not 50% of the people. So
I can mention from
there we
a
go.
disease point of view is that often in these countries there are parasitic diseases that migrate through the brain. So something like neurocysticercosis, which is a worm larvae that goes through the brain, and schistosomiasis japonicum. There are parasitic reasons for epilepsy that we just don't see in this country.
There we go. Was I scared for my life? In this conflict, actually being white is protective. That's not true in all conflicts. Certainly in Somalia, they're very happy to kidnap white people. But here, we actually found that if you just had a car transporting patients and there were no white people in the car would get held up a lot. If you put one white person in the car, it tended to drop those incidents. I think for whatever reason, it was a bit protective. We also always carry emergency money, so you get an envelope. I always had an envelope with $200 in it, and that's, if somebody starts harassing me, I can just say, here, have some money. And MSF is really, yeah. Yeah. There's always a security plan, so it's not the safest thing you could do, but the best thing is they always hire local chauffeurs. You're actually never allowed to drive on a vehicle with anybody else besides a local chauffeur, because that is truly dangerous. Last question.
I'm a paramedic, and I've always wondered why organizations like Doctors Without Borders and stuff like that don't bring in pre-hospital care, like EMTs and paramedics to assist with some of the pre-hospital, setting up additional pre-hospital care. Because I've never been to these other countries, but I've seen videos of how people from trauma get, basically dragged into the hospital, and how much additional injury that costs. I'm just wondering your thought about that.
I think part of the biggest problem is that a hospital trauma system, including pre-hospital care, actually requires a commitment of resources, including governmental resources. And I've seen people delivered by donkey. It's a huge thing. Our ER people are actually helping do that in India right now. So it can be done, but probably trying to do it in the midst of a war and develop a new system is probably not the time to be doing it. So I want to give Dr. Berry her opportunity, because she's going to help solve all these problems, I hope.
What I'm going to try to do in the next 40 minutes or so is talk about larger issues of global health, and that is all about equity. Because I think Dr. Ren is extraordinarily brave. I think MSF, which comes in emergency situations, but then leaves with very little infrastructure, because my program comes in after MSF, and we often see all the hospital settings pulled out, because that's an emergency. They do a great job in emergency care. But what I'd like to talk to you about is some of the larger challenges of global health, and this picture is sort of what made me go into global health, and this is just all about equity. For many years, as Phil said, I ran a program where I did send physicians overseas to these settings, and realized that I got more and more frustrated. That yes, it feels really wonderful to be curing on a one-to-one basis, but I got frustrated about trying to be somewhat more of a change agent in equity issues. So I got more and more interested in what is global health, how do we achieve global health, what is the definition of global health. And so I'm going to give you the 40,000-mile view from up here. I really liked it we changed orders, because Sherry gave you the upfront and personal, and I'm going to give you the zooming at 40,000 feet and thinking about what is global health, which is really an area for interdisciplinary study that really looks to achieve equity and health for people worldwide. And it revolves around these Millennium Goals that in the year 2000, the UN got together and actually got 100, this is an amazing achievement, watching what's happening now with climate control, that 192 United Nations members actually signed off on trying to work to these 8 goals, which is 1, eradicating extreme poverty and hunger. And for those who have not read Jeff Sachs' book about ending poverty, or at least Google the Macroeconomic Commission on Economics, it doesn't take very much to eradicate the extreme amount of poverty and hunger out there. Achieving universal primary education, promoting gender equality and empowering women, reducing child mortality, improving maternal health, combating HIV, AIDS, malaria, and the other diseases, and I'll spend a little, I'm a person that takes care of the other diseases, so I'll spend a few seconds talking about that. Ensuring environmental sustainability and developing global partnerships, as Sherry so eloquently ended her talk with. I'll just spend a few seconds on what they call other diseases, because this is what I made my career of, which is really tropical diseases. And these are the biblical diseases, the disabling chronic diseases. By the way, that was chromomycosis, that foot, but we'll talk about that later. The stigmatizing, poverty-promoting diseases such as elephantiasis. This is a disease, guys, that it's a mosquito-borne disease. It basically can be cured by one pill given every 6 months. It's outrageous that there are hundreds of thousands, millions of people going around suffering from elephantiasis, which, here's this microfilaria, I'm sorry, video person, I'm using the pointer, is really obstructing your lymphatics so that you get lymphedema and lymph leaking out. But you can see how that can be very disabling. I'll spend a little time talking to you about some of the work. I've collaborated with the Carter Center about a very old disease called guinea worm. And you can see this worm that actually is quite painful when it comes out. And if any of you remember the staff of Asclepius, the doctor's symbol, because often people use a stick to wind this worm out. That's actually the symbol of physicians. It's one of the earliest symbols that were used. You see it's the symbol for the AMA. But I don't want to talk about these sexy diseases. I don't want to talk about, this is really odd for me, to not be talking about malaria, chromomycosis, or tuberculosis. What I want to talk a little bit about are the missing agendas in the Millennium Goals. You saw those 10 goals, but I also think that we need to start thinking about not letting these other countries or countries that are now in transition make the same mistakes that we've made in our healthcare. And I know Alan Garber did give a talk about our healthcare system here, so I'm not going to spend much time about chronic non-communicable diseases, except to say that, believe it or not, greater than 50% of the deaths in places in the developing world are now cardiovascular disease, cancer, and I'll show you some of those slides. We need to think about some of the social determinants of health. What is it when you're stressed out by war and have constant gunshots around you and have no autonomy over your life? What does that do to your health? What do we know about road traffic and injuries? I mean, Sherry told you quite eloquently that the most dangerous thing in Africa is to get into a car, but it turns out road traffic, which is not as sexy an idea of HIV, kills more people than HIV worldwide. And they're not, you can see that on one of the Millennium Goals. Mental illness is completely ignored in the developing world. It's just not dealt with because there are too many urgent problems that take attention. I'm going to tell you that tobacco kills more than TB, HIV, and malaria put together. That's an amazing thing. And we're not, I'm talking worldwide, and I'll spend some time looking at those numbers. I'm not going to spend any time on war and post-conflict, because Dr. Wren covered that so beautifully. I will spend, and I'm not going to spend too much time, because I know that Dr. Skulnick talked about climate change and the health sequelae of that. But I will talk to you about something that I've become very interested in, because I don't think it's all about sending us there. I think it's about the fact that continents like Africa, which have 25% of the disease burden, have only 4% of the health workforce. And so how do you deal with that? You know, sending one Sherry Wren is like sending 1,000 regular surgeons, but that's still not making up for what the AMA calculates as a 4.3, actually Lincoln Chen has done all the beautiful work on this, 4.3 million healthcare workers that are lacking worldwide. So just to remind you, I want to just go back to that chronic disease, because if you take one thing from my talk, it's not going to be about tropical diseases. I'm sorry, Kathy. I know you want me to talk about this. It's going to be the fact that 50% of mortality now in the developing world is chronic diseases. It's ischemic heart disease, cerebral vascular, COPD, that's asthma and emphysema, diabetes. It is not diarrhea, HIV, acute respiratory, or tuberculosis. And if you look at the 2030 forecasting, it is going to be more chronic diseases. And if you look at the top causes of death and where we give money as a country, we're very generous in the United States. We're not so generous as a percentage of our GDP, but we still give a lot of, up to 25% of all bilateral aid. But if you look, we're giving it to HIV and AIDS, we're giving it to infectious diseases and maternal and child health, when really most of these countries are morphing into the chronic non-communicable diseases. And also, we need to start thinking about eco and zoonoses and living next to, when I say zoonoses, One Planet Health. And I'll talk to you a little bit more about what I think One Planet Health is about. I do spend a little time, just a very little time, because I've written in this area about what I call my eggs. These are my precious egregious globalization gaps that have actually, egregious gaps that have occurred with globalization. You would think, with all our wonderful knowledge, with the internet, with all our ability to trade culture and ideas, that we would be minimizing some of these gaps. But actually, I'm going to spend some time talking a little bit about what's happened with the economic gap, the pharmaceutical R&D gap, the literacy and what I now call the reverse digital divide, and we'll talk a little bit about cell phones, multinationals and their impact on health, the dietary gap in the obesity epidemic, which has it been covered yet here? No. Water and sanitation, which I won't cover because I know that Gary spent quite a bit of time with that, and then a little bit about the health workforce gap. First, as far as the economic gap, you would think with all this amazing trade and globalization that the gap in per capita income is improving. Well, we are getting wealthier as a world, but actually, if you look at the most wealthy, and just like in this country, we're getting a higher polarization, and that actually 100 out of 174 countries per capita income is lower than it was 15 years ago. And as Jeff Sachs has really burned into everyone's head, 1.2 billion people live on less than $1 a day. We are living longer, there's no question about it. And if you look at this curve in 1900, 1930, and 1960s, we're definitely living longer. But it's, as you get wealthier, you actually live a longer time. And that's a complicated socioeconomic issue, and I'll get back to that. Because it doesn't have to do with how much you spend on health. We spend, and I know Alan probably talked exhaustively on this, a huge amount of money on health, 16% of our GDP. And 89% of all global expenditures on health goes to only 16% of the world's population. But we're not getting our bang for the buck, which I'm sure Dr. Garber talked about. When you see that Cuba and Costa Rica live to the same age that we do, we're talking 1 year difference, 77 versus 78, and that Japan, that only spends 8% of their GDP, manages to have the longest lifespan. So what are we doing wrong? Well, let me talk about some of my eggs. I have to what I think we need to be thinking about, and some of it has to do with the gap in R&D in our pharmaceutical, the Me Too drugs. The world drug market is a huge market. It's now way over $607 billion. But if you look at where they're producing drugs and for who they're producing drugs, you can see that the world population is in this red part of the pie, but the drug market is only producing 9% for Asia and Africa. So that we're directing a lot of our attention at Me Too drugs. You know, how many statins do you need? How many Me Too antihypertensive drugs do you need? Why is it that of 1,500 drugs approved between 1975 and 2004, only 21 were for tropical diseases or tuberculosis? And for the area that I like, only 10. So there's a huge gap in our pharmaceutical industry and our R&D. Just to give you a small story that I got involved with, which is basically when our pharmaceutical industry took eflornithine, this is African sleeping sickness. This is basically the tsetse fly, which if you go on safari in Tanzania, I always see 1 or 2 cases a year. This is the trypanosome that actually causes sleeping sickness, which is a chronic disease in Africa. Which was really dropping down because we had a great drug until the company realized that this drug was a wonderful facial depilatory, took off women's mustaches, and actually took it off the market. And I'm sure you've seen the ads on TV, Vaniqua. So Vaniqua was what eflornithine was taken off the market for. So I have to say that physicians need to advocate, universities need to advocate, and societies need to advocate. And there was an outrage over this, and actually, with the help of Aventis, I happened to have been president of the American Society of Tropical Medicine at that time, and we really shamed that pharmaceutical company into putting this back on the market. And I think that was at a time, that was like 10 years ago. And I think there's been a real change in pharma. I think what we're seeing now, and I think this has a lot to do with the Gates Foundation, and I'll talk to you a little bit about that, is we're seeing now a real social consciousness emerging in public-private partnerships, and being able to counteract some of this pharmaceutical direct 90-10 gap. Has everybody heard about the 90, where 90% of the research goes to 10% of the diseases? So I think that's changing. And I think some examples are the product development that you see with some of the Gates-funded things, such as the Global Alliance for TB Drug Development, the Global Alliance for Vaccine and Immunization. This is where Gates and ministries of health and pharma get together and form these private-public partnerships where they actually do product development. We're seeing access partnerships, where a wonderful story, this is a great story, where Merck actually donated, it's probably going to cure this disease called river blindness, which is also a fly-borne disease that causes blindness in Africa. And they donated ivermectin, which you give to your dogs for heartworm. It's the same drug that actually can cure river blindness in Africa. We're seeing tremendous amount of discounting pricing with some of the new anti-malarials. And I think, and I'm probably going to show, well, I shouldn't show my politics. One of the good things that the Bush administration did was the Presidential Emergency Plan for Antiretrovirals, which actually got 10 million people on antiretrovirals. And Obama has, I'm glad to say, since I spent some time on his Global Health Commission, has committed $48 billion over the next 4 years of his administration to continuing this program, but continuing it in a different way, which I'll talk about. I think there's been some incredibly interesting financing mechanisms that have happened in global health. The Global Fund for TB, HIV, and malaria, which every country now donates into. We've seen amazing philanthropic, and this is the big gorilla in the room, which is the Gates Foundation, and with Warren Buffett now doubling, he just gave $37 billion, so that the entire endowment now is $60 billion. We're seeing, very ironically, a philanthropic foundation really calling the tunes and there's some, we can talk about that in the question and answer period, about some of the controversy over one foundation being one of the largest players in what are the priorities in global health. Because Bill Jr. has a very focused idea of technology and vaccines and single disease approach to global health. We'll talk to you a little bit about maybe other ways of doing it. And this may be one other way, rather than just focusing on tuberculosis or on malaria. Why not think about health literacy and the gap and how one can improve that? Because that really actually can make a tremendous difference in health. When you define adult literacy, the WHO, as the ability to write and read over the age of 15, 25% of the world's population is illiterate. 75% of the world lives in an oral and visual culture. There's a wonderful National Geographic about a year ago about this. If you improve women's literacy, even by 1 year, you wind up dropping fertility rates. Not surprising in my mind, but actually has been shown and documented in some very good literature. And also, if you increase literacy for women, you can find a statistical significant association with under 5 mortality, infant mortality, and the risk of low middle arm circumference, which is You saw some of those malnourished pictures in Sherry's pictures, but that's a marker of malnourishment for young children. So to me, yes, it's very important to have these vertical programs where you're trying to get at HIV and tuberculosis, but I think you need to talk about health infrastructure and building horizontal programs and larger issues such as literacy. And when you talk about literacy in 2009, or almost 2010, you can't talk about it without talking about illiteracy. And I'd like to just give you some of the statistics, is that 88% of all internet users live in industrialized countries. 4 out of 5 websites are in English, and remember, only 1 in 10 people in the planet speak English. And Africa has only 12% of the world, which has 12% of the world's population, really has only 2% of its telephone landlines, and those are all practically in South Africa, as I can attest to you. But what I think is the news story in e-medicine, and which is very exciting at Stanford, because many of our folks are involved in this, is that, yes, that's right, there's not very much internet penetration in Africa. It's only about 5%, whereas you can see that in the developing world and the rest of the world it's higher. But what we're seeing is this reverse digital divide. And that is how many cell phones are happening in Africa. With a billion population, there are now 415 million subscribers. On a per capita, it winds up being more than in the United States. It's become an industry there. And to me, this is the future until we get, it's a way to actually work with health literacy. It's a way to build up electronic records. It's a way, as Sherry was showing you, what she's working with in these very, and the gentleman that talked about what about those community health workers? We now have a medical student here who has wound up doing frontline medic. We're text paging community health workers so that community health workers can get back to hospitals and give vital signs and information. And actually, that medical student has also hacked into the phone so that he can actually, with help with folks at UCLA, they're developing images using the camera part of the phone to actually do malaria smears and CD4 counts and feed that back to a motherload computer so that a diagnosis can be made out in the field. So to me, this is a huge future. That medical student has dropped out this year, Dr. Pizzo, to further that for 1 year, just 1 year. I'm getting him back. But he's going to drop back in. We're going to, and I have to tell you, every morning I link on to ProMed, which is, to me, my lifeline to knowing what outbreaks are out there, because what I do is outbreak medicine and hemorrhagic viruses and tropical diseases. But to the surveillance, and for those of you who watched what happened with SARS and how quickly the entire world galvanized around a potentially fatal virus and identified it and found quarantine measures and preventive measures was pretty amazing. And it was all via the internet. So I'm going to switch to another egg, because I see some yawns in the back, and I'll go very quickly, which is basically, I think, something we can't ignore, and that's the multinational threat to global health. And I'll spend a few minutes just talking about, I don't think anyone's talked about the tobacco industry or the food industry. The tobacco industry, I have to say, there are 5 million deaths per year. I know that I'm talking in California, so probably less than 10% of you smoke in this room, so it's not an issue here, but it's a real issue in the developing world. This industry is targeting the developing world. When I'm in Africa, it's sold by the stick, by the cigarette, so it's cheap. And in the 20th century, it's killed 100 million people, and it's predicted, Richard Peto has done some nice studies looking that it will kill 1 billion by the 21st century. There are 1.1 billion smokers in 180 countries, and this is really an oligarchy. It's owned by 4 companies, Philip Morris, British, Japan, and China. But what is not kind of really talked about is that 75% of this crop now is grown in developing countries. And tobacco is a very depleting of soils and nutrients. It also needs to dry. So, like 2/3 of Malawi's forest has been deforested to cure tobacco, so that it has this other ecological ramification, this industry, besides just cancer. The global response to the tobacco problem has been impressive. Derek Yack has been one of the leaders in WHO in developing a WHO framework for tobacco control. I'm sorry to say the United States is one of the countries that did not ratify this framework, which is pretty benign, which basically bans sales to minors, promotes agricultural diversification, as I mentioned, because tobacco is so depleting, bans advertising, rotating health warnings, pretty benign, but the industry is pretty powerful here. Just an aside, as I almost got thrown out of Yale in my younger days because I actually, when they were targeting Africa, I actually asked my hospital to divest their stock of tobacco, and I did get them to divest. And then I went to the Yale Corporation and asked them to divest, and it turns out that the CEO of Philip Reynolds was a Yalie. And next thing I know is this guy wound up in my dean's office, this is before I was tenured, really trying to ask me to leave the university. Probably a story I never shared with you, Dr. Piso, before you took me, but I'm going to cause trouble here too. You know that. I'm warning you. For full disclosure. Well, we can work on other things, Phil. Don't worry. Don't worry. Oops, sorry, wrong way. This is, Yep. The next egregious globalization gap I want to talk to you about, and we are living in an epidemic. And this is the obesity epidemic. And for those of you who don't know what BMI, I know most of you do know what BMI, I just thought I'd put a simple, why they have to make this so complicated, but it's body mass index, which is basically your body weight in kilograms divided by your height in meters squared. And the definition is that if you're greater than 25 BMI, you're overweight, and then we all know who's morbidly obese. The gentleman in this picture is morbidly obese. And probably suffers from what we call metabolic syndrome and will suffer from diabetes and atherosclerosis. So what is it about? What's causing this epidemic? We had David Kessler come. Unfortunately, I was away. I didn't hear his talk, but he came, I guess, a week or two ago at Graham Rounds. And really, it has to do with what these multinationals, the culture around food that these multinationals have created. First of all, 4 transnational corporations own 90% of food exports and mass distribution of food in the developing world. God bless you. The WHO estimates that 10% of the world population have foodborne disease annually. So these TNFs don't do a good job in monitoring themselves. What they do a good job is making fats and oils cheaper, and soft drinks, high-calorie soft drinks, very cheap. And you can see that they've dropped dramatically over the last 20 years. And we get these macrosizing. I'm sure many of you have seen the Michael Moore, I don't remember who did Super Me, I don't remember who did it, but the macrosizing and the enter-eating. And it's no surprise that developing countries are now developing diabetes as much as the developed country. So this is a tough egg to crack, and this globalization in food. And because there's some things that happen when a country starts to transition. You get nutritional transition during globalization. You get this dietary convergence to foods that are high in fats and sweets and processing. You get global agribusinesses moving in. And I think, my own personal thing, I don't know if David talked about it, I think the real issue is, one of the real issues is urbanization. And the fact that you wind up eating outside of your house, the lovely gardens that the families come in the Congo to feed their family members are no longer, and you get 24-hour access to food. So that if no one's read the story of Walmex and what happened when Walmart moved into Mexico, and how Mexico wound up having a huge obesity epidemic that can be plotted around these super Walmex markets. But these TNFs can affect dietary change, and they converge diets with the Coca colonization and McDonaldization. It's really amazing how Coke is everywhere in the world, but we can't get IV fluids everywhere everywhere in the world. And it's very interesting because as we get a higher socioeconomic class in these transitional countries, the anthropologists have looked at this, you wind up going back to a healthier food dietary pattern. So socioeconomic class, determinants of health. Remember I said that was the missing agenda in the Millennium Goals. We need to know a little bit more about what are these socioeconomic determinants and what changes your diet. There is a strategy. If you want to go onto WHO, www.who.gov, you will see that the strategy for obesity and physical activity about limiting. I think Phil and I had a little discussion about making Stanford vegan, or what was it? No, we were laughing. But limiting trans fat, I'm a meat eater, so trans fat, free sugars and salt, promoting fruits and vegetables. There's a Healthy Cities project that WHO has started, which actually looks at urbanization and how walking and activity and plotting how cities can really make friendlier places for activities. And there's a potential for a framework convention, hopefully, with this. It's interesting, New York City labeled. Tom Friedan was someone I trained. He's now the head of CDC. I have tremendous respect for Tom. He did label foods in New York. He made all the labeling in McDonald's, and it turns out it doesn't change people's behaviors. So we need to know more. I get back to these socioeconomic determinants of health. What is it that's going to change somebody's behavior into a healthier diet and healthier physical milieu? I'm about in 2 weeks to go to this city, to Bangladesh, Dhaka, because this is what I think is one of the problems, are these mega cities and urbanization. Because between 1990 and 2025, the urban population is expected to double, increase from 2.4 billion to 5.5 billion people living in cities, and rise from 63% to 85% of the population in developing countries. This is going to cause a major crisis. And the major crisis, I know Gary talked a little bit about this, but I have to talk about this because it's close to my heart. And I actually wrote a piece that almost got banned because I called it Talking Dirty, the Politics of Water, for a very uptight New England type journal, which basically, these are the dirty facts. Of the greater than 6 billion people in the world today, 1 billion people lack access to safe drinking water, and 5,000 children die every day for want of a glass of clean water or basic sanitation in their community. And this has to do with many of the Millennium Goals, because each year 443 million school days are lost to water-related illnesses. And millions of women and girls, because it's usually the women and girls that are trucking these huge water things on their head, collecting water. And 50% of all people in developing countries suffer from a health problem caused by water and sanitation. So to go back to those 10 goals, if you look at water, you can see that if you improve water and sanitation, you'll probably improve malaria, because mosquitoes can't breed in stagnant water. You'll basically reduce child mortality because you won't have diarrheal illnesses. Each one of these Millennium Goals, even gender equality, because women won't be trucking those 4 hours to get the water, are affected by water sanitation and hygiene. And then I don't have to say this in California. I sometimes give this talk, part of this talk in the East, but you guys know about how scarce water can be and how scarce in supply and how scarce in access it is. But this is even more dramatic in parts of sub-Saharan Africa and in parts of Asia. I think I have time to just talk about a small intervention that I got involved with the Carter Center, which brings me back to my biblical diseases, which is guinea worm or dracunculiasis. The word dracunculus means in Greek little dragons. So that these worms, as I talked to you about in just a few seconds on a horrible life cycle, which this is the little vector which swims around in ponds. It's really microscopic. And basically, if you drink unfiltered water that has that little, you really can't see it, looks a speck. In New York City, everything looks like those specks. But basically, when you drink this water, this larvae are released from the copepod, which is that vector, and it takes about a year before this worm erupts from your body. And it's a very painful 6 to 8 months where people can't go back into their fields and work, they miss school. But the Carter Center did Jimmy Carter did an amazing thing. He actually is going to probably eradicate the first parasitic disease ever by just very small intervention around water and sanitation. That is not a Gates massive $30 million challenge. He basically hired little old men called pond caretakers, because one of the part of the cycle is that when a woman goes into the water to wash her clothes or to gather water, if you have a worm that's erupting, that's when the copepods are released. So the whole cycle needs a human to just step in water. So he hired these old men, these very old men, to sit at the edge of a pond and not let women basically go into the water. They would carry the pail of water. They would actually, he did this in Sudan, he did this in Ethiopia. He also got together, he was sitting at dinner one night with DuPont, and he basically, DuPont gave him these little nylon filters. So all you have to do is take this, basically a nylon cloth, put it over your water, and the copepods are easily filtered into your water. So with these two little mechanisms, having men, they did try to use some larvicides, but that wasn't really what worked. What really worked were these pond caretakers and the nylon filters, and then asking people to voluntarily quarantine themselves from water when the worm erupted. And you can see that it's dropped, and it's probably going to be the first parasitic disease. So low tech, low resource, around water and sanitation, you can cure parasitic disease that affected millions and actually had billions of dollars of ramification in agricultural. I'm going to end on health workforce gap because I did start like Sherry. This is me in my first overseas. I know it's hard to believe that I look like that. But the woman next to me now is the executive director at WHO in health metrics, Sally Stansfield, and we both spent several grueling months in Haiti. I'm carrying a child with Pott's disease there who's paralyzed. Pott's disease is tuberculosis of the spine. And I have to say the ratio of health providers to patients, and I'm not talking doctors here, I'm talking about health providers, community health workers, nurses, is dramatic between the industrialized world and the rest of the world. And that basically, it's no surprise where high density healthcare workers are and we're low density. If you plotted your less than $1 a day map on this, it would correlate with that. And it's no surprise that as you increase, well, this may be a surprise, but it actually has been looked at, that if you increase your health worker per 1,000 population, you can drop maternal mortality, infant mortality, under 5 mortality. But what you may not know in this room is that we are very much a part of this problem. And that in the United States, 25% of our workforce is basically international medical graduates, usually from English-speaking Kenya, Ghana, Nigeria, that we're very much a part of the brain drain. And UK has just recently put a stop to that. The US has not. UK has put a stop to their nurse brain drain, not their doctor brain drain. But Fitzhugh Mullen has done some very nice work looking at this. And so I'd like to just share with you some ideas that many of us have been sort of batting around with the Obama administration, with WHO, about countermeasures for brain drain. And clearly, number one is investing in non-conventional medical training to match local needs. We can't send the amazing Sherry Wren to do C-sections, but what we can do is teach community healthcare workers to do C-sections. And we actually have a gentleman here, a physician here, Shakti Shrivastava, who is going to be working with OBGYN people to do telesimulation to actually teach simple C-sections. We can think about task shifting to a non-doctor or non-nurse force. We probably should be thinking about this in the United States as well. I don't know if Alan talked about that. We can talk about innovative donor aid to enhance and top off salaries, because I can tell you that PEPFAR I love PEPFAR, it's done great things, but when PEPFAR moves into an area PEPFAR is the Presidential Emergency Fund for Antiretrovirals, every single doctor wants to work for PEPFAR because they pay them more money to give out antiretrovirals. What a waste. All this training to hand out, I'm the first one, I think HIV is a huge crisis, but you have this all other talent being brain drained. So there's this internal brain drain with all these NGOs coming in. I think we need to invest in physician and nurse supply in wealthier countries, and here's where I give Dr. Pizzo a hard time. We should be graduating more than 86 medical students. I know you're gonna say no, but that's the trouble I'm gonna start. But I think we need to be investing in increasing physician and nurse supply here so that we don't brain drain away from the rest of the world. I don't think we'll ever get, the WHO for a while tried to think about a central office. You can't stop people from migrating and wanting a better life and getting more money and wanting a better a life for their kids. I think that's fine. I have no problem with that. What you need to do is build incentives there and build capacity there that folks want to stay there. And my own heart is in twinning. And I don't mean by sending folks there, but actually in twinning in a true way of capacity building, where you actually work on site overseas. And I've, for the last 5 years, been working on a medical arm of the Peace Corps, which twins universities overseas with universities here, as well as twinning a Peace Corps force like MSF, but staying with a long infrastructure and leaving a legacy. It's in bill language. I don't know with the domestic health crisis now where we're going to find that money, but I'm confident that Eric Gooseby, who's now running PEPFAR, hears this need. I think everybody who has worked overseas realizes that number 1, 2, and 3, and 4 is workforce. You cannot roll out any of these Gates miracle vaccines or bed nets or anti-malarials if you don't have people that are there to implement it. So this is, I think, a huge egregious globalization gap that I think we need to advocate and crack. So I would like to end, because we're going to open it up for questions, of what I think we need to do to crack these eggs. And that is we need to advocate and commit to social and economic and cultural aspects of health and health behaviors rather than the disease-only approach. And I have to say this kills me, because I started my career with hemorrhagic viruses and tropical diseases and thinking about guinea worm and thinking about simple ways to eradicate or eliminate. And I thought and I still think one of the greatest public health achievements was the smallpox eradication, which was really a multi-country eradication of a disease. I think we need to assure that food, clean water, and health are basic human rights and protected from profit exploitation. I think we need to redesign essential drug policy and access to target generic products of breakthrough drugs with public-private partnerships, I think, going to be the way, and broadening our research goals to encompass a greater proportion of the global burden of disease so that we don't have this 1090 gap that I was talking about. And I'm going to end on a new area that's in my heart now, which is this concept of one world health and one planet, and thinking about climate and thinking about our living space with animals. And I like to end with this picture, because we're in the middle of, as you know, an H1N1. We live very close to, and if you look at the major epidemic diseases that have happened, whether it be H1N1, whether it be SARS, if you look at Guangdong and those marketplaces, which now they realize it's probably from the civet cat. If you look at West Nile, which came over from a goose from Israel on a plane and really spread. If you look at where most of our epidemic diseases have come from, it's really been our living space with animals. And I think that I'm not going to spend time, because I was told that Gary talked about climate, but I'm running a seminar series with Gary this spring and the Woods Institute on the health sequelae of climate change, because I don't think we can ignore our climate. So I'd like to end, I love ending with this picture, but I have to say that there's an unprecedented level of interest in global health. And these are just, I just kind of put together some of these public-private partnerships that are happening. I have to say that I've been so welcomed at Stanford. I'm in my office like inundated with people from the law school, the business school, the engineering school, the design school, all wanting Engineers Without Borders, Doctors Without Borders. We have the Janitors Without Borders. I'm waiting for our cleaning folks to come in because clean, sanitation, hygiene. There's an unprecedented amount of interest in this. And I'd like to say there are the brave heroines like Sherry Wren that go out there and risk her life. But I would like to really send out a challenge to everyone in this room. You're our new, you just spent 6 months in this, or how many months in this course? 4 months in this course. You've become very educated into health. I would challenge you to use that health information and go global with it. And I have to say global, and Phil may not like this either, is also local, our backyard. I think we also have an imperative to actually look into our, and there's been some wonderful work done by Chris Murray, because we look and say we live to 78, but if you look at who's living to 78, again, we get back to those socioeconomic determinants of health. So I offer you that challenge, and I very much look forward to working with you over the years to come. Thank you.
Okay, so we have time for questions. We have a pretty dynamic duo here. So, yes.
Two things. One, the question of not enough food and too many children starving. This is obviously not all due to civil wars. So what about that? You glanced over that. And,
well, I was given all of global health to do in an hour, so it was a little difficult. But food security, and there's a wonderful woman here named Roz Naylor, who has done a lot of work in this area, who I've just actually met. But there's no question. But you know what? We have a lot of that technology. I know that some folks, there's a lot of issues with Monsanto and seed and agro businesses. But I think that we have it within our technical ability to enhance food security and actually bring better food access. But it gets back to the issue of equity. I don't know, Sherry, you want to say anything about food?
Yeah, but I just want to say, I think you touched on this very well. It's really also just this commercialization issue, right? I mean, we're talking about the food industry and the tobacco industry, and the incentives are really misaligned, and they're about generating revenue and not being responsible in terms of the activities that they should be focused on. And this is not just a developing world issue. This is happening right here. Look at the disparities of where you find supermarkets, which are all around us, and where you find a lot of the fast food places, which is in the inner city urban areas. And so we do have, I think this was one of Dr. Berry's calls, we have some advocacy to do in our own community, right here in Palo Alto and East Palo Alto.
See, I know Phil is there. There are a lot of people working with this, actually, with food markets, but why don't...
It sounds like the low-tech model of the guinea worm solution applies to a lot of things, diabetes, smoking. It's behavioral stuff, and maybe where we put our supermarkets. But isn't there going to be a lot of leverage by doing low-tech, easy stuff and just making sure we do it?
I actually think that changing human behavior is a complicated issue, but that is where a lot of, and this is why I said the Gates priorities, they're the big money priorities now are going into anti-malarials, eradicating TB, and vaccines. I'd love to see a Gates-like foundation And I think MacArthur has tried to do this. They have a social, because my husband's part of this network, and the socioeconomic determinants of health. How do you change people's behavior? And it has a lot to do with bringing in anthropologists. But you're right. A lot of bang for the buck there if we can figure out how to do it. Do you want to?
I just want to add one other thing, which is, you know, innovation.
The question period.
So I'm here. If you didn't know that. But I want to comment on it because it's really Stanford-esque as well, which is innovation is something that students do really well. And I'll give you an example, and I know Michelle and Sherry are aware of this, but you know, there is a problem that occurs in newborns, which is they lose their body temperature, right? And there are a bunch of Stanford students who figured out a very low-tech, to your question, solution, which was developing a solar battery heater that would warm newborns, and that prevents or alters infant mortality. And you can go through countless examples of where innovation, technological innovation, simple, low-cost technological innovation can address these things, including clean water solutions. So that's where the universities can play such an important role in this, by using the power of the mind to create low-cost solutions in local communities as compared to here. And then they can actually come back and maybe lower the cost in our own communities as well.
Yeah, we've actually had one of the Stanford groups, I'm trying to remember their name, they developed the $25 prosthesis. So amputation, yeah, is a huge issue. I mean, it's a huge issue for anybody. And the difference between getting a prosthetic leg so you can actually walk somewhat normally versus not it's just a huge difference to the patient. And prosthetics are very expensive. In this group, it's like $25, right? Yeah, so it's, it was developed here, and I haven't actually seen it in the field yet, any place I've been. Most of the prosthetics that I see are donated, leftover prosthetics from the West, who then get shipped over. The question is, how do you change politics, in a short version? And how do you stop the wars? And whether doctors can play a role. I think you can certainly play a role. One of the interesting things, if anybody wants a somewhat interesting read, Nicholas Kristof, who's a writer for the New York Times, just wrote a book called Half the Sky, which is actually about women's equalities and gender rights issues. And he actually brings in a very interesting point, which is if you let women into politics and let women begin to get into these organizations at community levels all the way up through governmental levels, that you get a higher socioeconomic class, and wars begin to go away. And a real testament to that right now is Rwanda. Rwanda is reinventing itself as a country. They just joined the British Commonwealth this week, which was sort of interesting for an ex-Belgian colony. But they're kind of really pissed off at the French about that, about a lot of things right now. So, but because of so many men were killed, women, for the first time, had an opportunity to get involved. Now, I have no idea how you change politics. I think even in our own country, we're not sure how to do that. I don't know if you have comments.
I'll just say one comment. I think physicians should be advocates, and actually I'll be running a class. It's one of my first classes on how, for the medical students and medical residents, on how to become an advocate. And there is somebody in the pediatric division now, Lisa Chamberlain, who's really spearheaded that at Stanford. So yes, I do think physicians should be advocates. And I think you should go to your congressional representative. And it sounds crazy, but actually, I've actually been able to feel like I've made a difference. I may be delusional, but I think physicians can. And Phil, you do this all the time, advocate. So why don't you say?
Yeah, no, but I have another solution, which is I think that the way to deal with this is by a testosterone reduction methodology, which can have global. I was going to recommend that operation. Actually, you can start with a number of government leaders, past and present.
You had a question here in the second row, sir? End?
Well, it was more of a comment than a question. I mean, I think if you look at the congressional leadership in this area, there's a real tension because There are bills that have been introduced in Congress to, for example, broaden or extend patent rights on certain pharmaceuticals. And a lot of the political pressure for that actually comes from this area. So if you're really serious about that, I think that's a role that the med school can have in trying to better inform Congress about what some of the trade-offs are there.
The med students advocate, do they have a group?
Microphone?
Oh, so the med students have a group advocating for that. The students are amazing. So they actually wound up, I don't, they probably wound up in your office also, Phil? Did they? No, just mine. You sent them to me, huh? So that I do think the medical school at a higher leadership level, also besides medical students, could advocate that way.
It's wonderful that the Gates Foundation has focused so much funding on health in Africa and poor countries. Is anyone talking to them about the focus that maybe just developing a vaccine might be not the best way to go?
You don't talk to the Gates Foundation, but you can write articles. There's a wonderful article by Ravi Shankar et al. In Lancet within the last 3 months that is really a 10-page criticism about vertical programs versus horizontal and where has all the money gone. Because in actuality, a large percentage of that money has not gone to Africa. It's gone to the University of Washington to develop R&D. For good reason. There are wonderful people in University of Washington. But it's interesting, if you're going to build capacity, maybe you should be doing that R&D on site. It's a wonderful article. Ravi Shankar, like the sitar player. Sitar player? Yes.
Yeah. I think one of my most disappointing things is when they put out the Gates Challenge announcements, I open it every time, you know, because they're very exciting. You can get grant money to be able to do it, to be able to finally make an application to start changing the world, because I do want to change the world in some way, shape, or form. And there is nothing on their agenda that has anything to do with surgical disease. In fact, Paul Farmer, who I think a lot of people know who he is, Partners in Health, finally came out and wrote an article that made me feel better, where he said that surgical disease is the poor stepchild of global health. And it's just amazing. You can save lives, huge amounts of lives. As Dr. Berry said, there are more people dying of accidents than actually anything else, probably except for tobacco, will take more lives. But so it's, for me, a great disappointment when those calls get out twice a year to try and apply. I don't know anybody in the Gates Foundation, so they're certainly not going to listen to me.
I was wondering if you had experience with faith healers and more traditional medicine in some of the places you've worked, and how that interacts with what you two are trying to do.
I've had a huge amount of experience with faith healers. I've seen them absolutely kill people. We used to, it was very prominent when I was in Cote d'Ivoire. You could always see when somebody came in with so-called traditional medicine, their tongue would be very blackened, and they would have like a piece of roots and bark on the tree. We'd see people overdose from it, but it's very common. I mean, it's cultural. And again, if you don't have any medicines, if you go to a hospital or to a physician and you have an infection and you don't have access to medicine to treat them, faith healing looks pretty good. It's traditional medicine. It's not really faith healing. Yeah.
I've had a different experience. I've actually had a good experience. So I've had a good experience, but it's been in the United States, actually, because I did Indian Health Service for a little while. And it was clear that we made rounds with a traditional physician, and that was a very helpful thing, especially to get people with medication adherence, and also for mental illness. It was a very positive experience. So I think that there is a way to work.
Yeah.
Switched over, or whether whether people saw the Western way as something to do and stick with.
It's funny, just from my own personal experience, when you start talking about amputation, you would see people leave. You'd sometimes see them come back, you sometimes wouldn't. Oftentimes when they would come back, they'd have God knows what substance on things. Do you know how you treat burns in many third world countries? Toothpaste. Do you know how hard it is to get toothpaste off a burnt child? But it's cooling. I mean, you can see how this could happen. My favorite was toothpaste and rabbit fur was in one place where I worked. I don't know why that was the local thing, but so you'd have people covered in toothpaste and rolled in rabbit fur. Again, the other thing that there was actually just a great article in the Smithsonian Magazine is fake drugs. So you can go on the street and buy medications that you cannot get in most countries without prescriptions, and very powerful medicines. And fake drugs coming out of primarily Asia. It's a huge money. People spend money. They go to a little dirt counter and they'll buy anti-malarials or antibiotics, which may or may not actually have any type of drug in them. So it's just such a different healthcare system as a whole. So on the whole, most of my experiences with traditional medicine have been negative, but remember, I'm a surgeon, so I'm going to see the very bad downstream consequences, not the things that work. And cupping, burning people is actually very common, and ritual scarification. So you'll see burn marks on people to get out evil humors, and I don't know what, and where they'll cut them to, again, do these treatments. But again, if you have no health care, at least it's probably helping their minds.
But I would like to say that there are several drugs that have come out of traditional medicine, including our anti-malarial, our most effective one now, which is wormwood, or Artemisia compounds. So I think there's a way, and people have collaborated.
Absolutely, and I think it's important to underscore that, and I understand your experience as well, but I think it's important to at least recognize that there are lots of traditional medicines in different parts of the world that do have a basis and that do need to be better evaluated. And I would add that there are a lot of what we consider Western medicines that are way overused and have lots of consequences associated with them. So it's important to strike that balance and think pretty creatively about it. Yep, we're getting close to the end. Yeah.
I was just kind of a little grossed out by the images here, but I guess it's part of being a doctor. I was just curious how you find the strength to actually deal with what you see and actually treat that. It can make some people run away.
I've been a doctor a long time. Oh, the question is how do I not get grossed out or tired? And you have to understand, for me, I could probably eat while doing almost all of that.
I think that's a good note here. I wouldn't say anything else.
You just get used to it. The hardest thing about being a physician, especially in this, is trying to figure out when not to do something. And cultural, we carry our culture with us, and you're going into a place that has a very different culture. And that's probably been one of the hardest things. Here, if you're 18 or above, you can sign a consent form for anything, right? If I say to you, let me take out your appendix, you're obviously, you look older than 18, you could say fine, you'll sign the paper. In a lot of these countries, consent is actually a family affair. And to the point where a husband can veto a life-saving operation for his wife. And that actually is, some of those cultural clashes, to me, were some of the most difficult things I've ever had to do. I can look at that any day, but how, here we have a primacy rule, and how do you sort of accept that this guy is going to say no to something I know can save somebody's life, because it's not the individual. You get used to that. Give me some time, you'll do it.
Okay, I think we're going to, do you want to come together? I think we're going to come to our closure. I want to just thank a couple of people. First, I want to thank our speakers tonight. I think you certainly witnessed a lot of passion on multiple levels, and I think this is the stuff that changes the world, and that's what they're about, and hopefully we are as well. I want to thank Kathy Gillum, who's done just a terrific job in working on this mini med school, and it's been a real privilege. I've worked with Kathy for a long time, and she's done just a wonderful job here. And I want to thank all of you for coming. This room has been filled every week, and you know, our goal as we began this was to try and promote education and interaction. To one of my goals was also to promote advocacy, because a more informed community is more engaged in trying to solve some of the problems that we face. I hope you'll tell others about what you've learned, and that you'll share the knowledge and information, and you'll be able to do that more broadly pretty soon when it all goes up on iTunes. So that will allow you to relive all of these experiences. Or go back and relearn them if you're like me. Yeah, you did sign permission, and you're still being iTuned as you speak. But I also look forward to seeing you, some of you at least, in the next quarter. And again, thank you for being here, and go forth and do good things.
Happy holidays.
For more, please visit us at stanford.edu.